This is case L3 Ct A67. The history is that of a 46-year-old woman who has been well during her adult life, but is now experiencing within the past week some accelerating chest pain, now occurring with minimal effort. We start with general inspection of the study. We are here at the base of the heart, aorta and pulmonary artery. The aorta may be mildly dilated. However, if we make a measurement of it directly, we get a value of about 34 to 35 millimeters, which is in the normal range. Do note some atherosclerosis in the thoracic aorta, sort of mixed plaque with some non-calcified and calcified components. As we move down, look at the aortic root, normal aortic valve. Left atrium appears to be of normal size, and there is some mild non-calcified plaque in the thoracic aorta. And then as we approach down towards the apex of the heart, we can note that there is evidence of a hiatal hernia, which in consideration could be one of the potential problems in this otherwise middle-aged woman. We now turn to a review of her cardiac dynamics. This is a horizontal long axis view. Putting this in motion, we can see that there is very normal function involving the septum, apex, and lateral wall. Going to a vertical long axis view, you can see, again, very normal function in the anterior wall, the apex, and the inferior wall. Finally, turning to a short axis view, you can see again normal ventricular size, normal function. Right ventricle appears to be in normal size, also with normal function, and there is normal function involving the septum, anterior wall, lateral wall, and inferior wall. We now proceed to look at her coronary arteries, commencing with the left main. You have to be very careful when reviewing the left main, because often in very small vessels you may miss specific areas. If we examine her left main in particular, you can see that there is evidence of extra coronary opacification that suggests that this may be contrast media, but in review of the area of the left main, there appears to be focal significant obstructive disease, with the possibility that there is also some ulcerated plaque in this area. Examining the LAD proper, vessel appears to be generally normal, except for some very mild plaque in the mid-segment of the left anterior descending, demonstrating eccentric calcified non-obstructive disease. Now examining the left circumflex, this appears to be a very normal vessel, normal obtuse marginal branch. Continuing the vessel down distally, appears to be quite normal, even down into the more distal segments. This is probably a dominant or codominant vessel, depending on how you wish to look at it. This is the terminal circumflex. And then if you proceed, there appears to be a very small posterior descending vessel in this area, but the circumflex artery is otherwise normal. Finally, looking at the right coronary artery, we can in fact see that this is a very small, very diminutive vessel. It's otherwise normal, so this establishes that the left circumflex artery is clearly the most dominant vessel. In summary then, we have a 46-year-old woman who has had what now appears to be accelerating angina and has evidence of left main focal obstructive disease with possible dissection or ulceration in that region. She only has mild plaque noted in the mid portion of the left anterior descending. She also has sort of mixed complex disease in her thoracic aorta, but she retains normal left ventricular size, shape, and systolic function.